Already. So good morning, everyone. I'd like to begin before introducing our speaker for this morning with our land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So I'm very thrilled to present our speaker for this morning, Dr. Mohit Kahar. He is a pediatric gastroenterologist and hepatologist, an assistant professor at CHEO and the University of Ottawa in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition. Dr. Kehar joined the Division of Pediatric Gastroenterology as a staff physician in November 2020. So I'm sure he's eager to learn what CHEO is really like in a non-pandemic or post-pandemic state. We are very fortunate to have him here and hope to reward him one day with a proper office sometime very soon. Dr. Kehar was born in India, where he completed training in pediatrics and pediatric gastroenterology. He then moved to Sick Kids, where he completed his fellowship in pediatric gastroenterology, hepatology, and nutrition, and he worked for some time as locum staff after this fellowship. He then joined the faculty at Queen's University in 2018 as an assistant professor and was the clinical lead of the section of pediatric gastroenterology. Dr. Kehar is a hepatology committee member of the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, otherwise known as NASPGHAN, and is also a guidelines committee member of the Canadian Association of Study for Liver. His research interests include pediatric non-alcoholic fatty liver disease and pediatric hepatology. He's presenting to us today. His title is Non-Alcoholic Fatty Liver Diseases in Children, the Looming Liver Pandemic. So please join me in welcoming Dr. Kehar this morning. Over to you, Mohit.
So thank you, Dr. Chabar, for this nice introduction, and thanks for this opportunity to discuss today on one of the topics which is very close to my heart, so which is non-alcoholic fatty liver disease in children. And we'll discuss how this is like a ticking time bomb coming on our livers soon. So I do not have any financial disclosure for this talk. So the outlines of the talk is going to be some background information on what actually is non-alcoholic fatty liver disease, a brief etiopathogenesis, the epidemiology, and I'll also try to touch on this topic of MAFLD, so which is now being more and more used instead of using the word NAFLD. So MAFLD is basically metabolic dysfunction associated liver disease, and it has sort of created a lot of debate in the hepatology committee whether NAFLD is actually a right term to use, what we are using for past so many years. We'll discuss on the comorbidities that comes with non-alcoholic fatty liver disease or MAFLD, what are the current treatment approach, and what is in future for us. And hopefully by the end I'll be able to convince some of you that there is a hidden liver crisis just outside our doors. So with the evolution of mankind, people have seen a lot of lifestyle related diseases, and one of the most common one is obesity. And as we know, it's like a global threat nowadays. And with obesity, it came NAFLD, which was diagnosed way back in 1980s by Dr. Looming. So initially they saw a bunch of patients who mimicked like alcoholic liver disease. Their histology was like alcoholic liver disease, but they never consumed alcohol. So that's why this name came as non-alcoholic fatty liver disease, because they mimicked like alcoholic liver disease, but they never took alcohol. So it took roughly 20 years to understand that there was a close association of non-alcoholic fatty liver disease with insulin resistance and other metabolic conditions like diabetes. And over the past 20 years, this condition has taken a boom in the research, including multi-million projects like Litmus and Limbal, which are being currently in US, and Litmus is in Europe, for initiating a lot of biomarkers in research, and a lot of therapies are being eventually being in the pipeline right now. So NAFL currently, if you just Google, it has over 22,000 per med search and over 2,300 just in pediatric NAFL, just to understand the complexity and how much research is ongoing for this. So typically, what a typical scenario, how these patients presents is like a typical Caucasian boy, who is completely asymptomatic, might have complaints of fatigue here and there, with abdominal obesity and high BMI, and just on a routine screening is found to have elevated liver enzymes with the ALT of 60, AST of 48, ultrasound showing echogenic liver, and some metabolic disturbances, including high triglycerides, low HDL, with normal HbA1c. So that's how a typical patient of NAFL usually presents to our clinic. So what actually is non-alcoholic fatty liver disease? Basically, it's a continuum-alcoholic fatty liver, which is typically a benign problem. And there is only steatosis, that means accumulation of liver fat, but there is no inflammation associated with that. But a small proportion of patients of NAFL will progress to something called as NASH, which is an inflammatory phenotype. When you set in inflammation, and with there is variable degree of fibrosis from stage 1 to 4, and the last stage is NAFL cirrhosis. And this staging is ideally done on liver biopsy. And now I'll just try touch base about what exactly is this condition NAFL now. So there has been a lot of controversy about the use NAFL, because it is sort of a negative diagnosis rather than a positive diagnosis. So it tells what it is not, but it doesn't tell what it is actually. So all this debate started way back in 2002, when one of the single topic conference in ASLD proposed a term of MAFL, but only in the last year or so, it has been hot debated, and it has sort of divided the hepatology community into two parts. One favors the change of name and one do not. So just think NAFL being a big elephant in this room. And all these people are researchers who have their own class of research. And the condition is so complex that each of them sees NAFL with their own particular research class. For someone, it is just due to metabolic syndrome, but for someone, it is just genetic condition. For someone, it is a lifestyle problem, and for someone, it is just related to the gut microbiome. Unfortunately, neither of the terminologies were. So far, I would say we are just baffled. And for the ease of presentation, I'll just continue to use the name NAFL here on. So just last month, the researchers have basically generated a criteria for how to diagnose MAFL. So it basically says if you have a child who has steatosis or fat in the liver, which you detected on imaging or histology, if the child has obesity or excessive adiposity or abdominal obesity, or have type 2 diabetes or pre-diabetic, you can label this child as MAFL. But if the child has healthy weight, so this is the condition which we now call as lean NASH, the people who have normal weight but can still have fat in the liver, you need to have at least 2 or more of the metabolic risk factors, either being high triglyceride, low HDL, hypertension, or a higher triglyceride to HDL ratio, depending on their age spectrum. So how NAFL basically progresses, it progresses typically from a normal liver to a steatotic liver that has excess amount of fat, which a small proportion will move to something called as NASH, as we discussed, and then you have cirrhosis. Sometimes this progression is linear, but sometimes it is not. People have also documented that sometimes you can directly move from a normal liver to a NASH liver, and sometimes rarely even cirrhosis. So this coming to a pathophysiology of how and why it happens. Initially, it was thought to be just a two-hit theory, that you have excess amount of fat in the liver, which causes insulin resistance. And then because of the excess fat, you start all this mitochondrial dysfunction and oxidative stress. But it was found too simple to recapitulate all the complexities that comes with NAFL. And one of the complexity is the high heritability of this condition. And people have published variably depending on how they diagnose NAFL, and the heritability has been over at least till 50% in monozygotic twins. And in the last 5 to 10 years, there has been a lot of GWAS studies on genetic LI3 and TMSCF2. So PNB LI3 is one of the one that has the highest minor allele frequency of 0.26, and the highest population which has this MAF of 0.48 are Hispanics. And now we know that Hispanic population are at the highest risk of having NAFL or NASH-related cirrhosis. So it increases your odds of having NAFL to over 3%, and the same odds of over 3 for NASH as well. And then coming out from genetics to epigenetics, there is a lot of data on intrauterine factors. So people have seen that if you a high-fat mice give birth to baby, there is high risk of having development of NASH in the offsprings. And we also know that the low birth weight babies are at high risk of having NAFL later in life. And there is also dysregulation of hepatic microRNAs, which promotes lipogenesis and is highly associated with steatohepatitis as well as hepatocellular carcinoma in murine models. So with the epigenetic factors, along with the genetic factors, it basically what it drives from a normal liver to NAFL to a fibrotic liver. Sorry, I didn't quite catch that. Definitely there is much more to it. So just not to bore you guys with all this difficult pathophysiology of NAFL, but I just want to give you a sense about this complexity and how many different pathways works when the liver is being affected. So typically start in the adipose tissue as adipocytopathy with the insulin resistance. So with the insulin resistance, some of the patients will only have hepatic steatosis. There is no other problem. But in a small proportion of patients, it causes lipotoxicity. And with the lipotoxicity, there is endoplasmic reticulum stress. There is a release of all these oxidative stress molecules, which causes mitochondrial dysfunction. And there are at least 5 pathways that moves from here. Either it could be autophagy, it could be apoptosis, it could be extracellular vesicle development and inflammasomes. All these pathways or either one of them drives your immune system and activates something what we call as hepatic stellate cells, which causes fibrosis. And now there is wealth of evidence showing how gut microbiome also affects the liver. So there is a close association between the intestine and the liver path, which causes dysbiosis. There is also endogenous ethanol development, and it also alters intestinal permeability. This was a really cool paper that was published a couple of years back in Nature, in which what they did, they took 2 groups of mothers. One had normal weight, and other were obese. So they took microbiome from their babies, and then they gavaged germ-free mice out of those infants' poop, and they found that the mice who were gavaged with babies with obese moms developed all the features of NAFL. And if these mice were given
Mohit,
Western diet, they had worse outcomes.
Mohit,
They tested how important is the microbiome progression of non-alcoholic fatty liver disease.
yeah. Mohit, sorry
Yeah.
to interrupt you. So we're losing you at times.
Hello?
Yeah, I'm
Hello?
hearing Mohit.
Can you hear me now?
Yeah, if you turn off your video, your sound could be better. So it's just because the connection seems to be a bit broken. So that'd be good. Thank you.
I'm monitoring the, sorry to bother everyone. I'm monitoring the connection from this end. We're doing everything we can. His video has been turned off. So Dr. Mohit, if you want to continue, if we lose you, I will give you a call. Thank you.
Yeah.
Sorry.
So now coming from pathogenesis to epidemiology, so now it has been seen that it's sort of a global pandemic in adult as well as pediatric world. And the adult data suggests that the global prevalence of NAFLD is around 25%, and especially data from United States suggests around 25% of the adults have non-alcoholic fatty liver disease. Around 80% of them are obese with other metabolic risk factors. Around 25% of those people will develop what we call as NASH, and then around 25% of them will eventually develop cirrhosis and eventually hepatocellular carcinoma. So what it has translated, unfortunately, now that if you see this data that was just published a few months back, this is the listing of liver transplantation in adults. And you can see it is now the second most common cause of liver transplant in adults, even in younger adults in United States, in the not non-hepatocellular carcinoma listing. And you can see the boom of NAFLD if you compare from what it was in 2002 versus 2018. So it is such a rapid progression. And the similar trends are being seen in the hepatocellular carcinoma listing variety as well. And you can see it is one of the more common causes of hepatocellular carcinoma in adults nowadays. What about Canada? So this is just a cool study that was just published a couple of months back from Jennifer from Queens, which suggested that by 2040, virtually all patients who are adults with cirrhosis will be secondary to either non-alcoholic fatty liver disease or alcoholic fatty liver disease, suggesting the increasing problem in Canada as well. What about pediatrics? So data in pediatrics is a bit choppy, and depending on what diagnostic criteria have been used to diagnose NAFLD, but people have suggested that roughly the prevalence of NAFLD as a whole is around 10%, and it is can be upward of 30% in obese children. This was a meta-analysis that was published in 2013, suggested the same. And you can also see around 2% of prevalence studies also showed normal weight patients can also have non-alcoholic fatty liver disease. And similar to adult trends, we have been seeing change in the epidemiology of the chronic liver disease over time. This was an enhanced study that was just published, showing the NAFLD prevalence in United States has rose over 40%. And these children are usually male, obese, and have other metabolic dysfunction. And it was in tandem with increasing other non-communicable conditions and metabolic conditions like obesity, overweight, and dyslipidemia. And the similar trends have been seen globally, whether you are from a high or middle socioeconomic status countries. So I would say that the change was imminent, and it is here. So it has changed how chronic liver disease epidemiology we were seeing 10 years back versus now. So it's the most common cause of chronic liver disease in children. Unfortunately, there is no large population-based studies in Canada suggesting the prevalence of NAFLD, but we know that obesity is definitely increasing in Canadian children. And it was a Emerald database study from Ontario that was published in 2019, showing around 6% of Ontario children were obese, and out of them, around 2% had severe obesity. And the same trends were seen across Canada on using this chronic disease database. Around 10% of the children, Canadian children, were obese according to this database administrative study. So what happens with these obese children? Typically, they become obese adults. So it is highly associated with pediatric as well as adult NAFLD, and there has been studies, especially from Europe, suggesting that there is an increase of 16% per unit gain of BMI that scores at every age from 7 to 13%. So increases chances of cirrhosis in adulthood if there is an obese kid. But not all obese children will have NAFLD, and not all NAFLD are obese. So then it comes this paradox of lean NASH, so which unfortunately, as we know, that the BMI is not the great marker of body composition. And there is a group of patients who are metabolically obese, but they can have normal weight. And it's also important whenever you're checking BMI to use the right chart. So data in lean NAFLD is not as great in pediatric, but in adult world, it has definitely shown that there is a divergence of where you're seeing more lean NAFLD. So countries of the East like India and Korea have a higher proportion of lean patients with NAFLD versus North Americans. But lean NAFLD has same outcomes as obese NAFLD. So I would say that you do not have to be obese to have NAFLD, but if you are, it definitely helps. So what's the natural history? So natural history in children is not as well characterized as in adults, but 15% of patients who have NAFLD have stage 3 fibrosis or higher at diagnosis. So the fibrosis have 4 staging. The first 4 is what we call as cirrhosis. Typically it's said that one progression of stage of fibrosis takes on an average 10 years, but there are various genetic modifiers as well as patient specific modifiers, and it can also regress. So the data whatever we have is basically from the placebo arms of the trials that have been done in children. And just to know that placebo is not actually not absence of treatment in this condition, because lifestyle modification is the most effective treatment that has been evidence-based so far. And in those studies has shown that resolution of NAFLD or NASH is very uncommon. You can improve one stage, and although worsening is also as common as improvement. So this is the only available data we have on long-term outcome of NAFLD in children that was just published from Sweden. They have around 700 patients who are biopsy-proven NAFLD, and they were compared with normal population in Sweden. And they have shown that over 20 years, there is overall mortality of over 7% patients who have NAFLD in comparison to normal healthy controls. And that translates to one additional death per 15 patients with biopsy confirmed NAFLD over 20 years. So roughly there is one additional cancer-related death in every 32 children, one additional cardiometabolic death in every 50 child, and one additional liver-related death every 56 child with NAFLD over 20 years of time. It is really, really concerning. So now coming to other comorbidities that comes along with NAFLD. So NAFLD is epicenter, and it comes with a lot of other comorbidities. So I'll try to touch base on a few of them important ones. The most common one we see is type 2 diabetes. There has been a lot of data, especially from United States. This was a study that was done on around 700 patients with non-alcoholic fatty liver disease in children. Around 7% of them had type 2 diabetes, 23% were pre-diabetic, and it was found there's a higher rate of NASH or steatohepatitis if you are pre-diabetic or diabetic. The same is seen in PCOS, polycystic ovarian syndrome, in adults as well as in children. And it was found that if you have NAFLD, there is a higher diagnosis of PCOS in these population in adults as well as in children, because there is a greater overlap of the risk factors that translates into the diagnosis of PCOS and NAFLD. And the same has been detected in the pediatric study. This was a study that was published 2 years back, and they even generated a PCOS hepatic steatosis index, suggesting how they can use this index in the patients who have PCOS in children to diagnose who will have hepatic steatosis or not. The next one is cardiovascular disease. So cardiovascular disease is the most common cause of mortality and morbidity in patients who have NAFLD. And people have seen there is a higher carotid intimal thickness in these children, whether it is diagnosed, NAFLD is diagnosed by MR or ultrasound. And these children also have worse left ventricular function, suggesting there is ongoing cardiovascular problem even in pediatric age. And the other one which we see in clinical practice is hypertension. And people have suggested that around 11% of patients who are seen in NAFLD clinic will have hypertension associated. And typically these patients have higher LDL, higher uric acid, and typically are having higher BMI in comparison to those patients who do not have hypertension. The other one is a chronic kidney disease. So there have been multiple studies in pediatrics as well as adults showing there is a higher tendency of chronic kidney disease diagnosed by non-invasive measures. And they have reduced GFRs by Schwartz formula There was a recent study that came in hepatology suggesting chronic kidney disease evidence in pediatric world as well, and it was related to genetic modifiers like PNPLA3. And there was a large amount of meta-analysis data in adults suggesting there is a higher incidence and prevalence of chronic kidney disease in adults, but it is still not clear what happens to the patients who have this evidence of chronic kidney disease when the NAFLD improves. The other one is obstructive sleep apnea, and we've seen around 60% of the patients with NAFLD will have OSA, and typically these patients have higher diagnosis of NASH and fibrosis. So now we know that chronic hypoxia that comes with OSA typically activates a lot of pathways in the liver, including a hedgehog pathway, which is pro-fibrotic. Other is mental health disease. So depression is extremely common in patients. We don't know whether it is related to obesity by itself or whether NAFLD or liver disease has any play into that, but there is definitely higher evidence of depression in these children. So now coming to diagnosis, how do we diagnose? And this is like an asymptomatic condition, so extremely high risk. We need to screen these patients and keep a high threshold. So it's a diagnosis of exclusion so far, and we need to do fibrosis estimation as well as steatosis estimation, which basically serum markers, imaging modalities, and liver biopsy and clinical features all are included in the diagnosis of NAFLD. So as it's a diagnosis of exclusion, common conditions need to be ruled out, which can mimic NAFLD. So like hepatitis C, use of medications like steroid, methotrexate, things like Wilson's disease, ALCAT deficiencies, and uncontrolled diabetes, all of them can mimic NAFLD. Now coming to what is the role of ALT, we use it a lot. So whenever you're using ALT, so we should always use the cutoff that is for age and sex determined. So people say that in United States, they use this criteria of less than 22 for girls and less than 25 for boys. Anything above that is high. But ALT is not very specific, and neither it relates to what the phenotype or severity of NAFLD is. So elevated ALT, we should know, is not diagnostic of NAFLD, and neither it is diagnostic of steatohepatitis. Although people have seen that NASH is more common if you have an ALT of over 80. And then in Canada, we can use the caliper data to see, depending on the age and gender of the child, whether the ALT or AST is high or not. But as I say, that normal ALT does not rule out NAFLD. So this was the data from a NASH CRN group from United States, and they have clearly shown that around 20% of patients who have NAFLD have a normal ALT, and around 80% have only mildly elevated ALT. So mild elevation is less than 2 times the upper limit of normal, suggesting we'll be missing a lot of patients if I can only use ALT as a screening method. Now coming to ultrasounds, it is good for detection of steatosis. It is inexpensive, but it does not have great sensitivity and specificity. It is roughly to the tune of around 80%, and it cannot diagnose whether there is associated fibrosis or NASH. And the sensitivity of ultrasound goes down if the amount of fat in the liver is less than 30%. And BMI is more than 40, then also you cannot detect good amount of fat in the liver. So MR-PDFF is now, over the past 5 years or so, is coming a big thing in clinical trials as well as in clinical arena to detect steatosis. So this has an accuracy with the area under curve of over like 0.98, and the same has been reciprocated into pediatric studies as well, and with a cutoff of 3.5. It has over 95% sensitivity to diagnose any amount of steatosis, but unfortunately it's not readily available, and it also cannot rule out the presence of hepatitis or fibrosis. But nowadays we can use something called as MRE or elastography, which can be added to this MR, and it can give us some non-invasive estimation of fibrosis in the liver. So far, the gold standard for identifying whether you have fatty liver versus NASH versus fibrosis is liver biopsy. So you can basically check for severity, presence. You can also eliminate alternative diagnosis, and you can easily assess fibrosis. But the issue in pediatric world with liver biopsies that we see a different pattern of NAFLD in children, what we call as pediatric pattern or type 1 pattern, and it is completely different from the adults what they see. We have a lot more fibrosis in the portal tracts, and there is less ballooning what we see in pediatric world in comparison to adults. And because of severe amount of fibrosis in the porta, there is a lot of thinking that probably pediatric NAFLD is a much worse and aggressive form of disease in comparison to adults. So who to biopsy is still controversial, but people say that if you're at a high risk of having advanced fibrosis or NASH, like if you have persistent high ALT, you have splenomegaly, AST or ALT ratio of over 1, or known risk factor of high NASH or fibrosis like panhypopituitarism, type 2 diabetes, you should think about doing a biopsy. And when the diagnosis is not sure and before starting any therapy, and it also relies to the hepatologist's decision as well. But unfortunately, biopsy is also not great because there is a high intra-observer variability. So if you have the same pathologist to see the same patient slice twice over time, there is high chances that they're gonna report it differently. And if you ask two pathologists to see it in the same slide, they're gonna have different opinions. And then there is also sampling issues. The liver is always not affected as a whole at one time. So if you're taking a piece of the liver from area that is least effective, it doesn't help you. And then definitely because it's an invasive procedure, it comes with its complications. So because of all these issues, there is a ton of data and research that has been ongoing on what non-invasive measures we can use to estimate fibrosis. And there has been lots and lots of study. Unfortunately, so far, there is a lot of validation issues and there is a lot of cutoff issues, what to use because one study is not being validated by other, but there has been a lot of promising data upcoming from FibroScan and as well as MR. So FibroScan is something which we use in clinic as point of care and has been shown to have good results to diagnose whether you have fibrosis or not and whether you have cirrhosis or not. But the rest from F1 to F3, it's a bit of a gray zone. So what should we be doing? We should be actively screening these patients. The age and the need is still not clear, but the NASPGHAN or the North American Society recommends that if the patient's age is between 9 to 14 and you are obese, these children should definitely be screened. Or if you have a BMI between 85th and 94th percentile, and if you have risk factors, these patients should also be screened. And they recommend screening using ALT, but definitely there is a definite role of ultrasound because there is a group of patients who will have normal ALT and you'll be missing them. And if the repeat ALT, if the initial ALT is normal, then they recommend screening every annual to couple of years if the risk factor is unchanged. Coming briefly to treatment. So the goals of management is to regress NAFLD and to resolute their NASH and improve fibrosis. So fibrosis is what predicts bad mortality in patients with liver disease. Currently, the only available treatment that is evidence-based is lifestyle management. There are multiple trials in adults as well as pediatrics showing improvement of even NASH and initial phases of fibrosis with lifestyle management. In children, we do not have cutoff of how much weight reduction we want, but in adult, it has been seen if you reduce 7 to 10% of your body weight, there is dramatic improvement in histopathology as well, and I'll share that data later. So briefly about lifestyle modification, we usually recommend isocaloric diet. There is a lot of data now coming with improvement of NAFLD and other cardiovascular comorbidities with the Mediterranean diet. Juice is a complete no. So, and the same is for other sweet beverages because it contains a lot of fructose, which just goes inside the liver and generate fat, what we call as de novo lipogenesis. And there is role of moderate to rigorous exercise and limiting the screen time to less than 2 hours. And the diet in these children should have less what we call as advanced modification and products, which has been implicated in a lot of diseases, not only liver disease, but obesity, cancer, inflammation. And how to do that is typically to do home cooking, using steaming or boiling, using unprocessed food, eating more fishes, legumes, and low dairy products. And I got a lot of questions from families about what's the role of keto diet. So basically, keto diet is not that evidence-based, unfortunately, in our field. And whatever data we have from keto diet is from our neurology colleagues, because they use this a lot in refractory epilepsy. And we know there is a lot of complications and side effects of keto diet, including keto fluke, arrhythmias because of selenium deficiency, cramps, and a lot of GI disturbances. So probably that is why majority of the population consumes some amount of carbohydrate to avoid this chronic ketosis. So it's not the best thing what we should do. There's a lot of data upcoming on Mediterranean diet and its impact on steatosis as well as liver enzyme improvement in comparison to other diets like diabetic diet and low glycemic diet. And it's been more and more being used in adult as well as pediatric population with non-alcoholic fatty liver disease. What about Diet Coke? So I also get this question quite a bit from the families. So we know that diet beverages has aspartame. It's like 160 times more sweeter than sugar. There is unfortunately no human data, but in mice model, it has been shown that it causes a lot of lipid peroxidation in the liver, and it causes increased serum aminotransferases and lipids in the mice model. So it is not ideal either. Coming to physical exercises, so whenever we're telling the patients about exercise and diet, we should always tell them to keep what we call as SMART goals, what is specific, measurable, achievable, relevant, and timely. We should tell them how confident they are. We should give them some sort of action plan, tell them what are the barriers and what are the coping maneuvers if it doesn't work. Because only telling them go do diet and lose weight never helps. And give them some ideas how to increase their activity, like walking to the bus, getting off the bus one stop earlier, dog walking, walking groups, gardening, even lawn mowing. So we know that now that lots of short bout of activity likely have same effect as long period of time. So the more done over the day, the better. And diet and exercise both together works better than either of them alone. And then, just telling them go and lose weight, does it helps? Unfortunately not. And because we know that the frequency of the visit and the accountability of the patient, it improves their outcome a lot. So people have multiple times studied that there is a cohort of patient who comes to your clinic every yearly or 6 monthly versus every 3 monthly. There is definite improvement in their liver outcomes if they are seeing more frequently, because the patients are now more motivated and accountable. And the same has been shown in a study from Marilena that was done at sick kids a few years back, that patients were seen every 3 months versus every yearly, and there was greater reduction in their BMI as well as liver outcomes if they have been seen more frequently. And during these visits, you also screen for other comorbidities, and you should repeat the labs more frequently and have a close follow-up. So we know that in adult world, at least, there is data that if you lose around 10% of your body weight, you can have 90% of resolution of your NASH, around 80% of resolution of your fibrosis, and 100% improvement with steatosis. So it works great, but unfortunately, if you track all these patients for a year, only 10% of the patients will be able to achieve this weight by the end of 1 year. So it works, but it is not sustainable. Unfortunately, there is no medication that has been evidence-based and proven so far in adult as well as pediatric NAFLD. But there are several, like around 10 to 20 drugs that have been pipeline, which basically are working on different pathways, which we discussed in the pathophysiology. So each of this pathway has had a drug that is upcoming, that is in trials. So there are like 15 phase 2 studies that has been currently run in adults, and at least 5 of them are in phase 3 trials. And I'm going to just mention 2 of them, which gained a lot of media attention. What is this? Is Regenerate trial, that is a FXR agonist. Basically, FXR is something that helps to improve your bile acid pathway, and it has been closely related to fibrosis and steatosis estimation. And the data was read last year, and it has shown that it improves fibrosis by one stage. Unfortunately, there were a lot of side effects with this medication, including pruritus and a lot of GI upset, and they have been working on that. And this study that just came out earlier this year on semaglutide is a GLP-1 analog, which our endocrine colleagues and obesity clinics use quite a bit for weight management. So this the data shows that the patients who were on semaglutide have improvement in their steatohepatitis, but there was unfortunately no improvement in the fibrosis, which is basically the predictor of mortality in these patients. What about bariatric surgery? It's currently not recommended as a specific therapy, but could be considered if patients have higher BMI of over 35, they are non-cirrhotic, or other sleep morbidities are there, like serious morbidities are there, like severe sleep apnea, type 2 diabetes, or hypertension. The bariatric surgery could be an option in children. And then we should also treat their comorbidities, like if there is insulin resistance or type 2 diabetes. These patients are good candidates for GLP analogs, insulin, metformin. For dyslipidemia, statins are safe in liver disease, as well as fish oil. And for hypertension management, ACE inhibitors, calcium channel blockers, and limiting their dietary salt. But there are a lot of unanswered questions still, and there is a lot of work that needs to be still done. So NAFLD is basically a public health problem. So only hepatologists cannot unfortunately treat these conditions because of such high prevalence. So we need to engage the other primary care physicians, other specialists, and also engage policymaker for management of this condition, because it's going to be really troublesome in the next 10 to 20 years, what is happening. And we have shown this in a recent study that the primary care physicians have a lack of confidence in their pediatric NAFLD knowledge. They are not aware of guidelines, and they're not familiar at all about the spectrum of pediatric NAFLD. And the similar, we have been doing a larger Canada-wide study of over 65,000 children. Around over 10,000 of them were obese, and we have seen really poor screening rates of these children, and referral rate of only 20%. So the future of pediatric NAFLD, so we need to engage more and more family care physicians, improve their understanding of this condition, and also engage other medical specialists, because it's not only a hepatology problem. It just comes with a continuum of other issues, and increase the screening. And we need to also reduce the healthcare bias against obese children, because some of us just feel that they're just a bunch of obese kids with floating around with high liver enzymes. But we just need to understand that they also progress really at a really faster rate. And I've had patients who are cirrhotic at the age of 13 years, unfortunately. We need to also work on comprehensive integrated management and model it. Who are the patients who will be seen in the primary healthcare physicians, who will be seen in pediatrics, and who are the candidates who will be sent to a specialist. Unfortunately, there is no pathways in pediatric NAFLD. And as we discussed, there is a lot of more work that needs to be done on the non-invasive biomarkers as well as therapeutics. And eventually there is definitely a role of personalized medicines, because of microbiome signatures that is different between patients, as well as genetic signatures, whether, because there is a lot of data now that PNPLA3 could be used as a predictor of outcomes of the medications which we use in these patients. So to conclude, I would say that NAFLD is highly prevalent, and it can occur in young and lean children, and it can progress rapidly in children. Lifestyle intervention is currently only effective treatment, but there are multiple therapeutics that are in the pipeline, at least in the adult world, and hopefully in the next 5 to 10 years, we will start some good clinical trials in pediatrics as well. And there is multiple collaboration opportunities in this condition. Thank you.
Okay, thank you so much, Mohit, for a really great presentation. I first want to apologize to everyone, including Mohit, for the problems we had with connection at the beginning. I think Mohit's just making the point that he really needs a proper office at CHIO, so we are working on that. So I also wanted to thank you, Mohit, for really raising awareness to a very significant condition that affects many patients in our population. And when you consider, your discussion of all the comorbidities, you really had something for everyone in this Grand Rounds audience. I have one question for you before I turn it over to everyone else. And Carolina may be listening carefully to your answer to this question, but how do you suggest that we approach this issue of screening and referral to GI in particular for patients with suspected NAFLD? Given the problems with screening and given the potential, once we find them, what are we going to do with them problem? How do you suggest we handle that issue?
So typically, the recommendations have been that if children have more than twice the upper limit of ALT and that persists beyond 3 months, so they should be seen by a specialist so that we can do more testings, like including fibroscan, because as we know that ALT and ultrasound are not the best to diagnose either of them. So if they can be even seen once and we can do more testing on them, that can be helpful.
Okay, thank you. And Mohit, and I know you turned off your video to improve the connection. You can turn on your video again so that you might be able to, so people can see you better for your answers. So there was one question in the chat from Dr. Hajianakis about, which I believe you answered in your discussion about the GLP-1 agonists. I don't know, Stasha, if you have any further question about that.
No, thanks so much. I jumped the gun. That was terrific, terrific work, Mohit. I think that's such a challenging area, and just because it is so difficult to change body weight, I think we are in desperate need of other tools. So I feel hopeful for the GLP-1 agonists, but you're right. The jury's still out.
Yeah, me too. But when it comes to the liver, because it it affects so many pathways. So GLP-1 can address the metabolic path, but unfortunately, when it comes to the liver, there are so many other pathways like fibrogenic pathways and other pathways which are not being affected by GLP. So maybe down the road there is a role of some combination therapies that can hit multiple pathways together.
Thank you.
And that's why, lifestyle modification work, because it implicates and improves everything.
Just so difficult.
Yes, I know.
Yeah. We have a question from Dr. Sergey.
Oh, yes, Mohit, thank you so much for a very nice comprehensive review on NAFLD and NASH. I agree with you, targeting GLP-1 as just one pathway. Seen how the TGF-beta is not involved, and there is a lot of hope to get a more comprehensive therapy. And one aspect that I would like to discuss is, and you just mentioned at the end, is that the microbiome. I was involved in different microbiome research and also with liver and pancreas disease. And I was wondering if you can comment how the microbiome of an individual, specifically a child, is affected by using high fructose corn syrup in the diet.
Yes, definitely there's wealth of knowledge and evidence in the past, I would say 5 years or so, on how important our gut microbiome is for our health and disease. So dysbiosis has been shown in different models. Well, if you use high carbohydrate, there's a different microbiome. If you eat a lot of fat, there is different microbiome, and there is a lot of data on eccrimencia nowadays in relation to fructose. So people have been using eccrimencia even as supplement. People have seen that the patients who eat more fructose, they have reduced abundance of eccrimencia, which is extremely important microbiome for our gut. So there is a lot of, I would say, data that is upcoming and more trials that are coming on probiotics. Unfortunately, the gut modulation studies and therapeutics in NAFLD world, with the problem with probiotics is typically they're single strain, and it means if you use something like BSL-3, they have 6 or 7 strain. So whenever you're using probiotic, it has to be strain specific, and we need to target the microbiome which we feel causes the most important pathogenetic pathway. It involves the most important pathogenic pathway. There are at least 3 trials that are currently running on fecal microbiota transplant in NAFLD. So the data is still not out. They are still not completed. One of them is actively recruiting, but there is something called as a novel probiotic therapy in which people have been using multiple strains. So currently we are working on a group with LA to work on something called as a MET therapy in mice models with NAFLD. So that is something which we are working currently on. So hopefully we'll have more answers for you next time.
Perfect. Thank you so much.
Yeah.
I don't see any hands raised. I have another question for you, Mohit. You mentioned that very low birth weight infants were at higher risk of NAFLD. And I wondered, just thinking of our presentation last week about breast milk, exclusive breastfeeding or breast milk for these infants, whether that is tied to their microbiome as related to having received milk, cow's milk, as opposed to some other issue. Can you comment on that?
Yeah. So definitely there is a lot of data that, formula milk has higher predisposition of obesity and NAFLD in children as they grow. And the low birth weight people, it changes their intrauterine environment. And there is a lot of epigenetic that comes into play once, you're low birth weight in your mom's womb. And all this hypothesis about gene X, which we hear from Southeast Asia and Indian countries, that if you are just feel like if you are in a famine like conditions, you are for prolonged period you're not fed anything, and now you start eating, your body is just not ready. It just starts to just accumulate everything. God it just thinks that starvation or famine is coming down the road. So it just starts accumulating and everything, and keeps storing inside the liver. So that is one of the hypotheses why it happens.
Okay, interesting. So they're more in storage mode.
Yes.
Because of that. Okay, interesting. Okay, we have a question from Dr. Kavesi.
Mohit, thank you for a great talk. Can you hear me okay?
Yeah.
Okay. The other population where we see steatosis is CF patients. And these are patients who are typically more often slender. They don't have metabolic risk factors, but their ultrasounds show the same kind of things. What's the connection?
As you said that, NAFLD is a diagnosis of exclusion. There are a lot of other metabolic conditions that can also cause steatosis. Like a lot of inborn errors of metabolism can cause steatosis, but they don't have NAFLD. So this is a spectrum of patients who we call as pediatric fatty liver. They're not labeled as non-alcoholic fatty liver disease. So there is a group of patients who are just fatty liver, pediatric fatty liver. So they are not alcoholic fatty liver disease, because there are a lot of other causes that can cause steatosis in the liver. Because there are just different pathways that works, right? And that's why even the use of the word MAFLD is not 100% correct, because it doesn't explain the other metabolic causes, right? Outside the metabolic syndrome that can also cause steatosis. Like Wilson's disease can also cause steatosis, but it is not NAFLD.
Okay. Thank you. Any other questions for Dr. Kehar? Okay. All right. Well, thank you again for a really great presentation. You've given us lots to think about. There may be more referrals coming your way, but I think it's really important that we address this condition properly. Okay. Thank you again. Thank you, everyone. Have a great day.